Mm. Yeah, welcome everybody. I'm very happy to welcome you to this first Heckel public Zoom meeting. We want to begin with this event, a series of such meetings about different topics from oncology to post-infectious syndromes, like including post-COVID, pain therapy, chronic inflammation, and different topics. And of course, we are also very open to other suggestions from our users and customers. And I think the fever range whole body hyperthermia.
Excuse me, Stefan.
Yeah.
You want to record, right?
Yes.
Please record then.
Record.
Yes.
Yeah. Okay. And it's again here. Now I can record. It's here.
Okay. Recording in progress.
Okay. And the fever range whole body hyperthermia, you know, that has been used in a lot of clinics and hospitals of so-called integrative oncology, complementary oncology. And we have now, but in these clinics and hospitals, a lot of interesting experience have been collected, but unfortunately it was not a systematic evaluation of the outcomes. And of course, this is required. We have some scientific background. We have had more than 25 years systematic basic research on fever range whole body hyperthermia, mainly from Russell Park Cancer Institute. I'm very happy that Elizabeth Riparsky, one of the main persons in this field, is also in here today with us. And it's very interesting that just recently we see a lot of more interest from the more academic field. And I think that is because of the immunotherapy area that is now very important in the oncology, and people are suddenly interested. What can we do with these immune effects of fever range whole body hyperthermia? And if we go, I want just to introduce a little bit to you our new designed homepage. And you see here that there is a book, this book is here, an open access book, and you can download all these chapters. And there is also a chapter of Sebastian Czech, who will make the first presentation today with the title Whole Body Hyperthermia and Oncology, Renaissance in the Immunotherapy Era. Okay, please do also check the options of this homepage. If you go to Whole Body Hyperthermia, then you see here statements to the different indications. And also very important, if you go to science and you go then to running clinical trials, for example, then you see here in the running clinical trials, you see here also the study where Sebastian Czech will report about, and depression studies, and all these studies is listed here. And you can see also publications, whole body hyperthermia. And you see here that you can find most of the relevant publications in our homepage. Often it's just open access, and if it's not open access, write us an email. Okay, and here you have then the events. This has already gone, but next event is now the European School of Hyperthermia, thermotherapy. And then we are on the Astro there with the superficial hyperthermia. But I think that is enough from the introducing words. And I would now give ask Sebastian Czech from Charité to make his presentation.
Okay, thanks a lot for the kind introduction. Let's see if everything's working properly. Okay, I hope you see my slides now. Yes, okay, great. Yeah, nice that you introduced this new series. I think it's really interesting for the whole body hyperthermia community. My name is Sebastian Czech. I'm radiation oncologist at Charité, and I'm interested in whole body hyperthermia since some years. I will talk to you about the ongoing and final trials, my conflicts of interest. So first of all, as Stefan already mentioned, there's an ongoing interest in fever range hyperthermia in an oncological, and due to the immunotherapy in oncology, I guess. Sometimes I quote some older review article from the Netherlands from Chris and colleagues, where they stated that back in the 90s that the immune system doesn't play a major role in cancer. And I think in the 90s, this was still common sense. But now, of course, we all know that it's a really fantastic option to, since we can try to enhance the immune response against tumors. As you can see, most of these trials are on hepatocellular carcinomas, and there are only few trials, or there's none of the trials listed here. It's 2 publications which checked for all ongoing trials, and there are only two trials with, I say, extern or with thermotron hyperthermia. That means capacitive hyperthermia, basically. And most of the trials are with radiofrequency ablation, which is, of course, a much different effect. This is taken from the book that Stefan already mentioned, so I'm glad to do more publicity for this. Because as we know, the fever range hyperthermia and much work has been done by Elizabeth Riparsky, has on the immune system especially, but even on other aspects like central nervous system, hematosis, gut microbiome. And there are some studies on fever range hyperthermia. I will only do a quick overview. I won't show every study, especially not all the work of the preclinical work, which is probably most important, but just clinical data. Here, for example, one study with healthy volunteers, and they checked some cytokines before hyperthermia and after hyperthermia. And as you can see, you see an effect on important cytokines after hyperthermia. The same holds true in patients with, in this case, colorectal cancer. There you also see alterations of cytokines. But I have to say, in this context, of course, if you do inter-individual scans, then you have a really high variability, and we don't know if this is really important, these cytokine alterations. So I think it's a bit difficult to interpret this. I mean, you can interpret this that there is something going on in the immune system, but we don't really know what exactly is going on, and especially because it's only few patients in all these trials. And I think one of the most interesting study, and Stefan also mentioned this, which brought back whole body hyperthermia to a scientific, to the scientific interest of many, is this trial on depression. I won't show this trial in detail, but they did sham whole body hyperthermia and hyperthermia in a small group of patients with depressive disorder, and they had a long-lasting antidepressive effect. And interestingly, also here, they had shown that the cytokines are, even for a longer time, have some alterations. And in my opinion, what's quite interesting, I just want to go a bit more into detail into this plot. There you can see this color here. I don't know if you see my mouse, if you see my cursor, yes. So this group here is the control group. And as you can see, even in the control group, some patients, because you had the sham hyperthermia with the chamber heated up, so some patients had almost 38.5 degrees Celsius body temperature. And this is the interventional group. And then they measured the interleukin-6, which is important in an oncological context, but also probably in many other contexts and even in depressive disorder. And for me, because my PhD was on cytokines, and I was always a bit, let's say, I had some discomfort about measuring cytokines in patients because you have a huge inter-patient variability, but you also have a huge intra-patient variability if you measure at several different days. And for me, that's why for me, this is really impressive, this plot, that you see a pretty strong correlation for such a, let's say, volatile biomarker, that there really seems to be a relatively strong correlation with the heat. So I think that's an interesting finding. Now we come to the oncological trials that are ongoing or that have been recruited at Charité. We had one small phase 1 trial on recurrent head and neck cancer, only HPV negative disease and only previously irradiated patients. So this is a palliative treatment intent. And the hypothesis in this small trial was that we can reduce the hypoxia in the tumor by additional fever range whole body hyperthermia. There's really good preclinical evidence by Professor Ripasky for this. Here are some examples of treated patients. As you can see, it was not, or we didn't include patients with small tumors, but rather large tumors, as you can see in the FDG PET and the MRI. But in this case, unfortunately for us, this is the hypoxia F-MISO PET scan. None of the patients had any hypoxia before treatment, which was really surprising, because some data, or usually in head and neck cancer, the prevalence of hypoxia is around 50%, and there were some indication that in recurrent disease this is even higher, but we didn't see any hypoxia. And nonetheless, so the primary hypothesis of the trial was negative in this sense because there was no hypoxia. But what we observed, but it's really only extremely exploratory because it's only 5 patients in each group. It's a small phase 1 trial, not powered to show any difference. I have to emphasize on this. But what was a bit intriguing is that patients who received at least 4 sessions of fever range hyperthermia during treatment seemed to have a bit of favorable outcome in terms of local regional tumor control and overall survival. At least it was not detrimental. And as you can probably, or everyone who deals with head and neck cancer patients, especially with HPV negative disease, you know that it can be a bit challenging to recruit these patients, to motivate them for an additional treatment. So now we have a phase 2 trial where we said, okay, we really want to look for which kind of disease this whole body hyperthermia is most promising. And so we decided to do some basket trial, which is ongoing, where we recruit metastatic melanoma patients who receive checkpoint inhibition, metastatic pancreatic cancer patients who receive FOLFIRINOX treatment, metastatic breast cancer patients who receive palliative radiotherapy, metastatic sarcoma patients who receive first-line chemotherapy, metastatic HPV-associated squamous cell carcinomas with checkpoint inhibition, and metastatic prostate cancer patients with last-line therapy, that means PSMA radioligand therapy. And because we really wanted to see, okay, what can we do with this heterogeneous group? So patients get randomized 1-to-1 to standard oncological treatment versus standard treatment plus additional fever range whole body hyperthermia. And the primary endpoint is the reduction of circulating tumor cells before treatment to 3 months after treatment. I have to thank my collaborators in this regard, especially Professor Multor from TU Munich, who does all the work on circulating tumor cells, but also Professor Geipel and his team, who does the immune phenotyping, and of course all my co-workers at Charité, especially Julian Weingartner and my doctoral student, Christina Dumitrașu. Up to now, we have recruited 39 patients, or we have randomized 39 patients, and we have some really preliminary data on the immune phenotyping I want to show here. And it's important to say this is the change of immune cells pre-treatment compared to 12 weeks after treatments, where we do the second blood examination. So this is the delta, as you want to speak, before treatment and 3 weeks after. If you look at natural killer cells, standard of care, you see some increase, but you see a maybe more pronounced increase with the additional fiber range hyperthermia. The same holds true for activated NK4 cells. And really interesting in my regard, or as far as I know, is even that you see, well, you seem to see something for the T cells, activated T cells, but also PD-1 positive T cells. They are more or less stable with a standard of care, but you see a twofold increase by additional fiber range whole body hyperthermia. Of course, this is only really preliminary data. What we also look at is the patient-reported outcomes. This is an example of the CESD questionnaire, which can be used as a screening tool for depression. And if you look at the data, pre-treatment, standard of care, and fever range whole body hyperthermia, you see, or there might be a slight decrease in the score, but I would be a bit, So I would not interpret too much into this. What I have to say, interestingly, in the phase 1 trial on head and neck cancer, we had 2 patients who had really elevated CSD scores, which would be likely to be associated with depression, and they showed a steep decrease. So we will do the same analysis here. That might be more interesting than screening or than the data for all patients. And I think it's especially interesting because there's a recent publication from China on the association between emotional distress and immune checkpoint response, which is quite strong in my opinion, because you see a really dramatic improvement of progression-free survival. And interestingly, in this work, they also looked what happens if patients have emotional distress, but this improves, then even the outcome improves. So I think that might be quite interesting to look at this. And another aspect is we have a quite a big questionnaire on patient-reported pain. And as you can see here, there's no big difference between the pre-treatment reported outcome here of patients, so the pain, and in the first follow-up, pain was much less likely to be reported in the fiber range whole body hyperthermia group. But of course, this is all really preliminary data, but I think interesting to look in the subgroups. And this is especially interesting. I think I have seen Hussein Sahimbas too. There's one publication from Iran on a phase 3 clinical trial with radiotherapy plus fever range whole body hyperthermia. in my opinion, so they had a really extremely strong effect on pain relief reported in this trial. In my opinion, one problem of this trial is that the complete and partial pain relief for radiotherapy only are too low, 5% and 32%. Usually we have a response rate of 70% in palliative radiation oncology. So for me, that's a bit difficult to interpret this data, but maybe we can discuss this, especially as Hussein Zahimbas is also here. So I think the early data on the immunological parameters of our ongoing clinical trial are quite promising, but it's extremely preliminary. I have to emphasize this. It's not exactly clear. I think it's probably not that straightforward. We will also look at the cytokines, but I have some doubts if cytokines alone will explain this. And I think it's good that we do this extensive immunophenotyping together with the University of Erlangen. And in my opinion, of course, it's worth further investigation. We have other domains of patient-reported outcome measures too, but we seem to have some improvement of pain and even the depression scores. I think we will look into detail for these patients who have high scores in this depression screening questionnaire. It's only a screening questionnaire because I'm not a psychologist, neither psychiatrist. But I think that's interesting to do the same as for the head and neck cancer patients, to see, okay, patients who have quite high values, do these patients have an improvement by additional whole body hyperthermia? I think this is a really interesting topic, especially due to this new data from China. So I'm happy to discuss with you because I have the next meeting already at 5 o'clock, unfortunately in person. So maybe we can discuss now.
Yes.
And thanks a lot for the invitation.
Thank you very much for the presentation. So I have two questions. One is, you mentioned several whole body hyperthermia treatments. What was the spacing in between the therapies? Did they receive it on a weekly basis? Was it monthly? And were they combined with the standard of care, or was it independent of that?
No, it's always combined with the standard of care. As I said, checkpoint inhibition in melanoma, FOLFIRINOX in pancreatic. So it's always standard of care.
But I mean, in a timely manner, was it like chemotherapy followed by whole body? Or...
Yeah, so it depends. Yeah, it was always chemotherapy. Usually we say within 1 day of oxaliplatin, we apply the whole body hyperthermia. For checkpoint inhibition, we are a bit more less restrictive because we know the half time of checkpoint inhibition, and so we say usually within 2 days we should apply the whole body hyperthermia, but we are not that strict. For the radioligand therapy, we do it immediately before PSMA ligand therapy. What else? Yeah, so usually it's we try to do it quite close to the systemic.
Okay, so it's bound to the standard of care treatment.
And it depends a bit, like we plan usually 4 cycles of whole body hyperthermia within this trial. But for example, for radioligand therapy, it's only every 8 weeks. So we only do it twice in this group, but that's the only group.
Okay, then my second question would be, you mentioned an NK cell increase. Was it about the NK cell count? Was it about the cytotoxicity, cytochrome release? What was measured there? I didn't quite get that.
So I have to admit, I'm not the expert here because this is Udo Geipel's work basically, but they do a FACS analysis basically, and they look for activated NK4 cells. So they do it with markers on the surface of the NK cell. So, but they don't do any functional assays to further.
Okay. Then one last thing, I'm currently working on my doctoral thesis on exactly that topic, whole body hyperthermia, with a pilot study on 6 patients with extensive immunophenotyping and so on. So if you'd be interested in maybe sharing some of your expertise or getting together, if you'd like to see some of the readings we get, or if you have some interesting things we might need to consider, then I'd love to, maybe if we could share email addresses just to get together.
Yeah. Absolutely, would be great. I'm glad, because we have that few trials on whole body hyperthermia. I think it's extremely valuable to pool the data and to have a closer look. So I would be really glad. So 1 second. But I think you can also contact Stefan, who can give you my.
Yes, we've been in contact with Mr. Heckel back at the Hyperthermia Congress.
Okay. Yeah. So
I will tell you the contact data for each other.
Very
make a note and then.
Okay, while ISZK is on, because there is also another colleague who has a question, but while we are on, so we are an immune oncological center, and of course, if I see an increase in IL-6 and an increase in TNF-alpha, that is in fact a pro-inflammatory situation, which might be an issue in cancer, at least. So we should think about that. But in the depression, I'm not sure in how far inflammation has an effect on depression and what this link is. But I came then to another question, which maybe nobody has thought about, but we now know that the gut-brain axis, for instance, in relation to depression, plays a very major role. And therefore, my question, is something known on the influence in the intestinal flora of being 4 hours in fever range whole body hyperthermia? Is something known about that? Because that might influence somewhere also your effect.
I think there's some preclinical data, but probably I'm not the expert on this, but when I wrote the book chapter, I think you can have a look in the book, because I think I found something, but there's no really good evidence on this, I have to say, of course, because also because the gut microbiome is pretty, not pretty new, but it's like the interest in the gut microbiome is pretty recent. And I think there are not that many, or there's only really 1 publication maybe on this, 1 preclinical, and there's no clinical data as far as I know. And as you said, with the IL-6, that's completely right, valid point. And because the authors of the depression trial, they had the hypothesis in the other way around, that IL-6 should be decreased, because I think there are some publications that IL-6 correlates maybe also due to this inflammatory status with depression. So they thought it should decrease, but they saw exactly the opposite. So it's interesting, but they still have an antidepressive effect.
Oh, how do you raise your hand?
Bob, yeah.
Yeah, so I have a question. It's relative to what you said at the beginning about that you expected hypoxia in the tumor, and it didn't show up in the scan. And as we're trying to prepare to do something, trial in locally recurrent breast cancer here, when I talk to the doctors here, and we're talking Maryland, Cleveland, University of California, San Francisco, they talk about that the oncologists hold the patients for a while because they've now got a larger portfolio of systemic drugs to use. And what ends up happening is they'll say maybe it works a bit and then burns out. And, by the time they end up seeing the patients after the menu of systemic drugs, the local tumor really progresses. And that seems to be the general the general observation. There we go. And so my question is, you know, Stefan and I had a little bit of discussion about this, about whether, you know, why that might be happening. And I think the supposition or was discussed is that, you know, the systemic drugs are probably not getting to the tumor in enough density. And so logically that fits. But we see these patients continue to progress, and they, you know, they end up when they end up getting treated with radiation plus hyperthermia, there's you know, there's good outcomes, but usually by the time they get the patients, and this is with the smaller version of the microwave, the tumors are far too big. So my question to you, and it may not be your precise expertise, but you work in this area, is what might you expect that's going on? Because what you had said earlier is there was no evidence of hypoxia was surprising to me, because that logic fit for us.
Yeah, same for me, because I mean, it was extremely, as I can say, you know, these hypoxia scans, they are really a mess. I did some research on primary head and neck cancer before with Michael Baumann, and there we had really had a lot of patients, and as I said, the prevalence is 50%, and there's a huge impact on the outcome. And I think generations of radiation oncologists have been obsessed with this hypoxia, you know, like, and I think it's important, because not only due to the drugs, because in radiation oncology, we need the oxygen radicals. So for us, it's not only important for the drugs, but also for the radiotherapy. And for me, this was completely surprising. There has been no investigation on recurrent or previously irradiated head and neck cancer. There had only been one investigation with a mixed cohort, where there was one patient with an hypoxia scan with recurrent tumor, and this patient had quite high hypoxia. So our hypothesis was that it would be at least 50% or maybe even more in this previously irradiated patients. But I was completely surprised to say this, because we spent a lot of money to do these hypoxia scans. The tracer had to travel from Austria 800 kilometers for each patient. And I think maybe because I talked to some other radiation oncologists, head and neck experts, and they said even with the gene expression, they see really dramatic differences between the primary tumor and the recurrent tumor. And so this might be one response, because we don't really know what's going on. And it might be, I think I can imagine that primary breast cancer is still quite hypoxic if you have this dramatic effect of hyperthermia.
These are always secondaries, doctor.
Okay.
It's locally unresectable, locally recurrent.
Okay.
Sorry.
Okay. No, but I mean, like a highly aggressive disease like head and neck cancer, but I can only speculate. I guess that maybe you have these smoldering cells, tumor stem cells, which may at the beginning not be that extremely aggressive and dynamic, and therefore you might have a better vasculature, and you don't have this extremely chaotic neoangiogenesis, and therefore maybe you don't see this hypoxia in the PET scan. But that's just one speculation, you know. But I hope we will manage to do some additional gene analysis with the first cohort, but I don't really have a good explanation for this, unfortunately. We were all surprised.
I think we have to go on, because we should start the second presentation. I think, thank you. I have only one additional question. If you use oxaliplatin, then the hyperthermia is done the day after, or?
The day after, usually.
Yeah.
Usually
okay, that is maybe,
because otherwise it's not really feasible. And it's also because they have the oxaliplatin and then they have the 5-FU. So we do it during 5-FU more or less.
This just the question with the timing. This was one idea found from an experimental animal study of John Bull in University of Texas, where only if you, in the combination of oxaliplatin and fever-range whole body hyperthermia, only in the timing of hyperthermia 1 day after the chemotherapy, you saw a very good effect. And we interpret it like that you need the immunogenic cell death by oxaliplatin, and only on this base of an increased antigen presentation, the first unspecific immune stimulation by fever-range whole body hyperthermia can turn to a kind of to stimulate a specific immune response from the timing. Yeah. But then I would ask now, thank you so much, Sebastian. Thank you very much. And then I would ask Dr. Pinto from Hospital da Luz in Portugal to start his presentation.
Okay, thank you. Are you listening, Stefan?
Yeah, we are listening. Yes. It's okay.
And
okay.
You can see the slides, yes.
Yeah.
So I will start by thanking Stefan for this really good initiative. It's good to put everyone interested in the same topic together for us to discuss what is happening and moving forward, and also provide excellent presentation. And Sebastian moving forward with also evidence in randomized trials, specifically associating whole body hyperthermia with standard of care treatments. I'm from medical oncology, so I'm quite interested in enhancing the effect of standard of care treatments, and that's what we do in Portugal. So patients that are treated with the standard first line, we might add whole body hyperthermia to that standard first line, second line, etc. And we are not changing the oncology treatment of those metastatic patients by adding whole body hyperthermia in this case. So I brought you 3 cases of patients that I've treated with good responses. We'll start with the first one. It's a 44-year-old patient. She had a right breast carcinoma in 2003. She was hormone receptor positive, HER2 negative, and she was treated with metastaectomy, lymphadenectomy, adjuvant chemotherapy, and hormonal therapy. And in 2011, she was detected with BRCA2 mutation. She did not have prophylactic surgery back then, so she had a left breast carcinoma afterwards in 2013 with hormone receptor positive, HER2 negative, and Ki67 of 5%. She did surgery again back there, and since sentinel lymph node was negative, so she started tamoxifen, but suspended after 1 year because she was tending to get pregnant. Then on May 2015, she had localized recurrence in this left breast with skin and lymph node involvement. She was treated with neoadjuvant chemotherapy with docetaxel and carboplatin for 6 months. Then she was performed surgery, and here with bilateral oophorectomy because of the BRCA mutation, adjuvant radiotherapy and hormonal therapy with letrozole and tamoxifen. Afterwards, 8 months afterwards, she had a PET CT scan that showed disease progression, now with lymph node, bone, and liver metastases. And in this time, she started first-line metastatic treatment with carboplatin and paclitaxel. And on April 2017, she had new disease progression and made hormonal therapy with palbociclib and fulvestrant. And I've met the patient now on this setting. So she has disease progression after hormonal therapy with extensive lymph node involvement, also bilateral hepatic lesions, the largest one with 35 millimeters, and extensive bone involvement, and also lung metastases that you can see on the PET CT scan. And the patient started capecitabine, and we associated whole body hyperthermia back in the clinic back then. And on August 2017, 1 session per month, she was doing induction to 38.5 degrees, with around 1 hour and 15 minutes of retention, and max temperature was recorded 39.5 degrees Celsius. And after 3 sessions of whole-body hypothermia with concomitant capecitabine, this is third-line metastatic disease. As you can see, the PET-CT scan showed an almost complete response of the disease, which we are not expecting in third line with capecitabine, especially in a patient who has a really poor response to a doublet chemotherapy and platinum-based doublet chemotherapy and also hormonal therapy before. So maybe we hypothesize that whole-body hypothermia may, by somehow, increase the response of capecitabine. We don't have, these are not randomized data, these are clinical cases, so we don't know the exact effect of one compound and the other, but in our clinical practice, we are experiencing better outcomes that we were supposed to have by those lines with standard of treatment by adding whole-body hypothermia. So now I change to the next case, and now we change to a colon cancer, metastatic colon cancer, a 62-year-old patient that has a diagnosis of an adenocarcinoma, and they was treated with right hemicolectomy with lymph node dissection, a PT3N0M0 RAS mutated. It has some minor risk factors and was decided to do adjuvant chemotherapy with 5-FU until November 2016. And afterwards has progressive disease, and the total length of the target lesions was 113 millimeters with hepatic and also a peritoneal carcinomatosis involvement, and started in another hospital, EFL, which is an old version of FOLFIRI, with partial regression of these lesions. Then she changed to FOLFIRI bevacizumab, not by progression, but because she changed to a bigger hospital that was treating with standard of care. And as you can see here, she had an initial response to FOLFIRI bevacizumab, but she's staying with this treatment for more than 6 months. And after achieving a partial response, she has stable disease from that point on. And normally in oncology, when we achieve a partial stable disease that we see for several months, normally we don't have another response afterwards. So we normally have partial responses, then we have stable disease, and we don't have like 6 months after another partial response without changing the treatment. But in this case, the patient decided that she wanted to do whole-body hypothermia in association with this treatment. I explained to her that we would like to do these treatments by the beginning to measure the effects as we start the new line of treatment therapy. But she decided to add this after several months of doing FOLFIRI with bevacizumab and with stable disease. And she achieved a partial response after this without changing the FOLFIRI plus bevacizumab treatment. So she has target lesions from 77 to 58 millimeters, and also other lesions that were not considered target ones, but by the radiologist, they were metastasis, they had complete response, included 2 lesions in the lung, which made her move, being able to be operated. She has liver surgery and also peritoneal surgery, and achieved an R0 resection after this. And she was, I lost follow-up a few months afterwards from her, but the first CT scan after the surgery was clear of disease. So here we don't have anything changing in the same patient, just by adding whole-body hypothermia and a partial response afterwards, which might be in some case related to this treatment. And now we move to the last case that was presented in ESHO last year. It's a patient with 63 years old. She has personal list of hypertension and a really good performance status. And she had localized gastric cancer that was treated initially by partial gastrectomy, a PT1N1 with MSS HER2 negative and no expression of PD-L1. And she had adjuvant K-pox with 8 cycles, and she was in surveillance. A few months afterwards, she had a lymph node recurrence, periaortic and common iliac recurrence. And we decided to start treatment with K-POX, and I discussed with the patient, including nivolumab, although she has a CPS of 0%, because the analysis to exclude these patients is a subgroup analysis, and we know that there are some patients that benefit from immunotherapy in this setting. And explaining both of this evidence, the patient decided that she wanted to associate nivolumab, as patients do normally, with CPS of 1 or increased. And she associated all-body hyperthermia for 9 cycles. And she has a partial response initially, or almost a complete response afterwards. And then after 9 to 10 months, the PET-CT scan showed somehow disease progression. We have never biopsied this supposed progression, because it was not feasible without surgery to get to these lymph nodes. And so we discussed in the MDT meeting, and we decided to change to a second-line treatment with FOLFIRI. And the patient had all-body hyperthermia because she had a really good response before, and she felt quite good about doing that. And she wants to continue to do this treatment. And then she has a new partial response, and the next CT scan showed a complete response. And she went to another institution that proposed that she had surgery for that lymph node recurrence. And she did, and she had a complete response. So we have a stage 4 gastric cancer with a complete response to chemotherapy, initially in association with nivolumab, afterwards just FOLFIRI, with all-body hyperthermia. And she's disease-free for more than a year now. I see her like every 3 or 4 months now in the clinic. And all the CT scans from that surgery until now did not show any recurrence of the disease. One important factor about this patient is that she developed somehow a tolerance to whole body hyperthermia. So in the first 8 cycles, normally she took around 1 hour to get to 38.5 degrees. That's the target temperature that we try to achieve in the induction phase. But afterwards, she started to take 1 hour and 30, 2 hours, or more than 2 hours to achieve that temperature. And in the 12th and the 3rd cycle, she could not even get to 38.5 degrees. And so we stopped doing all-body hyperthermia because we could not achieve that temperature, and it was taking too long for the patient to get there. So we empathize that somehow there are some underlying mechanisms that if you do a lot of sessions, you might take longer to achieve the temperature or not be able to achieve the 38.5 degrees. And we were having other patients being treated at the same time. Everyone was fine in achieving the temperature. It was specifically for this patient, and nothing has quite changed that explains this. So this is our 3 of just to launch this discussion of clinical cases. I don't have the data published of all patients treated. We are quite new in all-body hyperthermia in this center now. In Portugal, we have it for a long time, but we acquired a few. In the beginning, it was difficult to start the treatments here, but now we are doing mostly in association with first, second-line treatments. And for the first around 15 patients that I see the results, all patients that had more than 1 all-body hyperthermia treatment in association, we did not have any disease progression. So we have around 80% of patients that had a partial response, and around 20% with disease stable, but any patient had progressive disease. And this obviously, even if we are talking in association with first-line colon cancer or gastric cancer or breast cancer, those are response rates better than we would see with the standard of care treatment. So I believe that might be an effect on incrementally chemotherapy or immunotherapy effect, but we have more questions than answers, especially regarding when to do it. And as the questions were saying to Sebastian, if we should do it in the same day, next day, if we should do it twice a week, once a week, every time that we do a chemotherapy. And all these questions are what makes difficult for us to publish our experience, but everyone is doing a little bit different, and then it's hard to put everything together and build from there. So I'm really thankful to Sebastian to try to do randomized patients in standard of care procedures to really try to see if there's a light of efficacy in randomized trials. So we thought a bigger one after that. And thank you.
One question. Have you maybe considered weight gain in that patient that developed the resistance to whole body hyperthermia, since you mentioned she started when she was in full-blown progression under chemotherapy, that she maybe just gained weight, which oftentimes from clinical experience prolongs the time patients need to get temperature, that once she finished chemotherapy, when she was out of progression, then she just naturally gained weight, which then prolonged the time?
No, she's quite thin. She's like 50 kilograms and always has been like that. So there was no weight increase or any change in the patient itself.
Thank you.
That would be a good explanation. And I've discussed this with some patients in ASH, with some doctors in ASH that they do a whole body hyperthermia and has a lot of experience. And they say that sometimes they see this happening, and they even try to give something like an induction to try to increase the temperature before, but this is not specific from this case. There are other doctors that are seeing this also. I don't know if you have anyone here that has a lot of experience also in associating with standard of care treatment that would like to share their experience.
Well, we just ended a trial in the University Hospital in Antwerp where we treated patients with advanced metastatic pancreatic cancer in combination with gemcitabine. And we are now setting up a randomized controlled trial where we will add hyperthermia, whole body hyperthermia with standard of care GemNab. And we will randomize in two groups, standard of care versus GemNab together with whole body hyperthermia. A little bit of a disclaimer. First of all, we are a competitor of Stefan, but we know each other quite well, so I hope he's not angry with me. And we also we work at a higher temperature, so we induce 41.5 degrees in the patients, and the patients are under full anesthesia.
Okay.
By the way, we from my point of view, we are not even competitor, because with our system, we believe this is a very good system for fever range whole body hyperthermia. We don't think this is the ideal system for extreme whole body hyperthermia with patients without consciousness, heavily sedated. And therefore, I'm very happy about your group working on a new technology for extreme whole body hyperthermia, though that is not even a competition in this field. And I look forward very much to our cooperation. Yeah.
Thank you. Thank you. Same for me. So that's no problem. And thank you for the initiative, because I think it's a really great initiative.
Yeah. Is there any, especially are there experiences from other users? And also a question to Dr. Pinto. Have you an idea in what group of patients, in what oncological indications is the most could be the most interesting field, or do you think it's a little bit about all solid tumors?
I don't have a lot of experience in all tumor types, so mostly I have in digestive, like GI cancers, mostly because I treat also lung cancers. But lung cancer, most of our patients are in clinical trials, so we cannot add whole body hyperthermia in patients that are in other clinical trials. So most of the patients that we are starting are in GI cancers, and those data that I'm sharing are mostly about these patients. Sometimes one or two patients with breast or ovarian cancer, but mostly is from pancreatic, colon, and gastric cancer. So I would not think that the response will vary that much by organ, but mostly by the improving or its relation with the chemotherapy. It might have some effect, but I would believe that it's more related with chemotherapy itself, if it improves or not that mechanism of action. But we know that there are tumors that are immune resistant, and especially in those, if whole body hyperthermia could recruit some of these patients to benefit from immunotherapy, that will be a really good change. And we even on tumors that we treat nowadays with immunotherapy, we know that only around 20% of those patients will really benefit from that. And if we can increase the number of patients that do by somehow benefit from immunotherapy, even if it's not anti-PD-1 or the next ones that are coming from now, this will have a huge impact on a lot of people, as we can recruit more immune dead tumors to be treated with this good therapeutical treatment.
Yeah. Hussein?
Thank you very much on both for both presentation. The duration of the total body hyperthermia maximum time was 2.5 hours. It means the total procedure, or the top of the temperature was 1.5 to 2 hours?
No, normally it's around 1 hour and 30 on the top of after 38.5 degrees.
Okay. Thanks.
And I think we find it, if we increase that time, it would be difficult for patients to complete the treatment. So if we are doing 2 hours and 30 of whole body hyperthermia above 38.5 degrees, that will be hard to maintain patients coming every week or every 2 or every 3 weeks, because it's a long time, because they have the induction period, the treatment period, afterwards period. So I think it will be hard to put all the patients doing that without sedation, of course.
I think, sorry, is there a question from you? Okay.
Yeah, I think generally speaking, therapy adherence is one of the major issues that I see from clinical experience in whole body hyperthermia. It is quite exhausting. As someone who does it, has done it myself, it is quite exhausting, especially once you reach the temperature. Are you working fully without any sedation? Are you using mild sedatives like benzodiazepines? Are you doing it completely without?
Completely without, yes. Patients that do sedation by themselves for depression or something, they take the pill as they do it every day, but we are not doing any sedation specifically for the whole body hyperthermia.
Thank you.
I think there is also the data about immunological that tumors like pancreatic cancer. The data from Schilbronn, they published a comparison of chemotherapy alone or chemotherapy with whole body hyperthermia. They found quite a big difference. It's published in Cancers. You can see it also in our homepage. It's open access. Have you had any experience with pancreatic cancer in Portugal?
Yes. I have a patient that is doing treatment now. He's a patient that had, let me remind, he has borderline resectable pancreatic cancer, started FOLFIRINOX initially. He did surgery and completed the adjuvant treatment. And after around 1 year, he has local regional recurrence with lymph node recurrence around the pancreas and not metastatic disease. As it has moved more than a year, we did FOLFIRINOX again, and in association with whole body hyperthermia, and the patient responded quite well. He had a partial response, and then we did radiotherapy, chemoradiotherapy, as he was starting to have a lot of infections related to the, how do I say it in English, the proteases that he had with cholangitis. He had like 3 in a row, so we were not able to do chemotherapy. So we decided to stop in doing, and we did chemoradiotherapy. And he was without disease for at least more than a year after that combination. And he recently has progressed with lung metastasis and a huge increase in CA 19.9. And now we decided to do gemcitabine with nab-paclitaxel, and the patient wanted to associate with all-body hyperthermia as he has a good experience before, and he's having a partial response, at least by the marker. Now he's getting down quite quickly. He hasn't done the CT scan yet. He's doing it next month. So this is the latest one that have been treated with pancreatic cancer. Let's see. More questions.
More questions?
I have a quick question. Do you know what's actually driving the response? Is the cancer cells, we talked about hypoxia earlier, but also is the cancer cell more compromised when it's at an elevated temperature, or is this sort of driving immune response in the body? Do you understand what's driving the incremental bump, or incremental response?
Yeah, we just have the data that we all have from a long time ago, most of it, as Sebastian has talked about. We haven't done like preclinical data or collections on this, but I would assume that would be a mix of everything. So we have probably an augmented immune response, and by somehow tumor microenvironment might be changed with the changing of temperature. And by somehow shifting this to either chemotherapy gets there better or acts better when he gets there. But how exactly does this happen? I think there is no data around that. We just get this hypothesis of how it works.
I appreciate your
it can work. Yeah.
Are there any other questions or contributions?
I have, hello everyone. I have a question. So there's a lot being talked about cancer metabolism nowadays, and I wanted to know if someone here has experience inducing hypoglycemia, low blood sugar, hypoglycemia, and then performing the whole body hyperthermia, because it makes sense to suppress the cancer cell first and then induce the fever for a better use of the hyperthermia.
I personally do not have.
I think the only user, but now unfortunately retired, was Dr. Santos Martin in Barcelona, who did that. And I think we want to make a similar event like today, where we have more the questions to combine whole body hyperthermia with modified cancer treatment protocols, also in combination with curcumin infusions, but also with, for example, hypoglycemia and things like that, Also that is, but this is a good point that we really enter this question. I think it's an important question, absolutely.
There is a publication from our group here.
Okay.
Just have a publication on the several issues of the tumor microenvironment. So the cancer stem cells, the hypoxia, the metabolic dysregulation, that all has somewhere an influence on the shifts in the inflammatory compartment. So if one is interested, we can pass this publication to everybody who wants to attend. But it made me also to the question about the mechanism. So we have an immune suppressive tumor microenvironment. There are disbalances in the myeloid compartment. That is quite well known. There is very roughly said the M1 and the M2 macrophages. And the M2 macrophages are rather to be tumor promoting at the end, in part by blocking the anti-cancer T cell responsiveness. If we now know that TNF-alpha is increased, that was the first speaker from Berlin, and the IL-6 is increased, that means, in fact, there are pro-inflammatory components. Has there been a thought, and eventually in preclinical models, to first change or try to change the balance in the different myeloid compartments before you come in with whole body hyperthermia, where you in fact stimulate these inflammatory components? Just as an idea, we know from a Cell publication that the M2 macrophages have PD-L1 expressed quite high, and they block the immunization of CD8 T cells over a trail mechanism. That's why we try to target these cells with an anti-PD-L1. We know also that these M2 macrophages are histamine receptor positive, so you can target with an antihistamine receptor 1 blocker. Has there been, as if maybe you know it, has there been attempts to change your balances in the myeloid compartment before you come in with your whole body hyperthermia, then only stimulating an M1 myeloid compartment effects because you depleted just before your M2 myeloid compartment effect?
So I personally do not know about that. Is Elizabeth Ripowski still in there? But maybe she had to leave. Oh, but this is a question. So I'm maybe also, of course, not competent for this question. I only know that, for example, in a model with arthritis, in an animal model with arthritis, and even with ankylosing spondylitis patients, we found that direct stimulation of IL-10 and other anti-inflammatory cytokines. So I'm not sure if this is in cancer different, or if we have only this pro-inflammatory effect or also at the same time an anti-inflammatory effect. But this is, of course, a question that could be discussed in a deeper way.
Yeah, somewhere we have to, we give a stimulation which is very aspecific. The whole body hyperthermia is a very aspecific stimulation. But before, we can design the balances in this way that we can take better profits of the aspecific stimulation, only stimulating those cells that are in interest of us. That could be a good idea.
Okay. Are there at the moment other questions or contributions? I have in the end a question. We are just in the time now, but what do you think? Is this format something we repeat, or I have the feeling now that it was maybe to make also, in addition, that we make meetings where we have a more detailed question. So, for example, just a question about pro and anti-inflammatory effects of hyperthermia or something, even in the oncological field, more specific questions, or what is your idea how we can develop this format? I think this format is good because it's easy to do, and we can bring a lot of people together. And in addition to Congress where we meet each other, what is of course also necessary, I think we should develop that. Is there any opinion or how we can organize that in the future? Yeah. Hello.
Yes, hello everybody. Thank you very much. I learned a lot and I like this format, and it would be great to have further sessions like this. And what we would be very much interested in would be the question of the antiviral effects of hyperthermia. And since there is also oncoviruses and viral causes in certain tumors, this even also has an importance concerning the oncology question. So I really would be very interested in further sessions like this with such follow-up questions.
Yeah.
Thank you very much.
We will do. Thank you. Yeah. Good. Okay. Then if there is any other idea, discussion, question, contribution, criticism, then I would.
I have to. I'm sorry. I have to.
Okay.
I have to thank everyone here, and especially you, Dr. Heckel, for this opportunity. What I want to say is that at least in our region, in our country, this is something very new, and the way to introduce it here is to load up ourselves with tons of information from research, with the collaboration from the different groups in Europe and in US. So yes, I'm also keen with this kind of activities, so we can share the information, and it's going to possibly make things easier for us to introduce hyperthermia in our country and the Latin American region. So thank you very much.
Okay. Okay, then I thank all participants. I thank especially Dr. Pinto for the excellent presentation, and for me very encouraging, because we know that there is a potential of whole body hyperthermia. We also know that that is not a miracle therapy. We have just to develop and look more and more where it's indicated and where it might be not indicated. And in this critical way, let's progress. And thank you very much for all participants. And then we will inform you. We will continue this format. We have the idea to do this maybe each 2 months with different topics. And so I hope to see you again. And with this statement, I would close and thank you and wish a good evening, or even in Colombia or other countries, a good day.
Bye.
Bye.
Bye. Thank you.
Bye.
Thank you. Thank you,
Bye.
Stefan, to you.
Yeah.
Bye.
Bye.
Bye-bye.
Thank you.
Bye.
Bye.
Bye-bye. Thank you.
Thank
Bye-bye.
you.